Speaker today, Dr. Laura Stinson, is a academic detailing pharmacist with a background in community pharmacy and medical education. Welcome back, Dr. Laura Stinson.
Thank you, John. My financial disclosures, there's nothing to disclose here. So I'll move on and go over the practice gaps. So for patients with opioid use disorder, the rate of smoking is much higher than in the general population, and many of these individuals are not receiving treatment for their tobacco use. The learning objectives that we're going to talk about today. So, we're going to discuss the rate and risk of co-tobacco use and opioids, list some pharmacologic or medication options and behavioral interventions for smoking cessation in patients with opioid use disorder. We're going to talk about the relationship between nicotine and opioids, and then talk about some barriers and hopefully some ways to overcome the barriers to smoking cessation in patients with OUD. As far as outcomes, after this session, I hope that participants will be more likely to discuss tobacco with patients that they are working with that have opioid use disorder, and will feel a little more comfortable doing that, and that they'll understand the differences between tobacco use in patients who use opioids and those that do not. And again, that they'll try to think of ways to overcome barriers to smoking cessation. So I'll start out talking about tobacco use in the United States. So right now, about 14% of adults in the United States smoke. And even though that number has gone down, it was over 20% in 2005. So even though the number is decreasing, we still have over 31 million adults that smoke cigarettes daily. And that's not consistent across the country. So you can see the different colors here on this map for different states, and that represents different percentages of tobacco smoking. And of course, Kentucky is one of the higher states. So the darkest blue color there represents the highest state. So Kentucky is 23.4%, and the other states with the highest use are Arkansas and West Virginia. And then you can see California and some of the West Coast, the percentages are a little lower there, and that ranges from about 9 to 12%. There are substantial costs associated with smoking. So the total economic costs are over $288 billion each year, and this includes healthcare expenditures and lost productivity. So this is due to premature mortality. So people are dying sooner and therefore not able to work. This does not take into consideration lost productivity due to morbidity, so illnesses that would prevent people from working that are attributed to their tobacco use. So this total number could be higher if you thought about those costs as well. So specifically for patients with OUD that smoke, the numbers are much higher. So over 75% of persons in OUD treatment smoke cigarettes. And then for individuals that are not in treatment, the numbers are in the 90s. So 92% in one estimation of persons who use heroin, and 95% of participants in a syringe exchange program. A syringe exchange program. So the numbers are much higher than the 14% that represents the general population. So why is there a difference? There are some possible explanations. There are biologic mechanisms that are involved with cigarette smoking and opioid use. So they stimulate similar reward pathways. And we'll talk about that in a little more detail a little bit later, but they reinforce each other. So people who smoke cigarettes are more likely to use opioids, and people who use opioids are more likely to smoke cigarettes. And smoking reinforces and enhances the the effects of opioid use, and the same opioid use enhances the effect of smoking. One reason that might contribute to this is a drug interaction between the cigarette and the opioid. So, combustible tobacco, so a smoked cigarette, produces chemicals that induce the enzymes that break down opioids. So, opioids are going to be broken down in your body faster if you're smoking compared to somebody that's not smoking. So, people can tolerate higher doses and they may not have the same effects at a dose compared to somebody who is not smoking cigarettes because their body is getting rid of it faster. There's also a relationship between tobacco and chronic pain. The range for tobacco smoking in persons with chronic pain is 24 to 82%. So, again, that is higher than the 14% for the general population. Nicotine dependence is associated with initiation of opioids. Like I said, people who smoke are more likely to use opioids. Nicotine dependence is associated with chronic opioid use and less decline in opioid use. So people, once they start, they're going to stay on the opioids longer and they're not going to drop back down to a lower dose. And in fact, nicotine is associated with high dose opioid analgesic use. With acute use, so short-term use, nicotine does have some analgesic properties. So it can cause pain relief in the short term, but with chronic use, people develop tolerance to this effect. And actually, their pain receptors are sensitized and they have increased pain sensitivity. So they're going to report higher levels of pain. So on assessment, their pain scores are going to be higher. They're going to report that their opioid doses are insufficient or their pain management is insufficient because they have kind of a hyper response to pain due to chronic nicotine use. And then their chronic nicotine is a risk factor for some conditions that are chronic pain conditions that could be associated with opioid use. And this includes back pain, sciatica, arthritis, fibromyalgia, and chronic headache. So there's kind of a natural progression, and some prospective studies have looked at adolescent smoking and the contribution or the progression to having chronic back pain. So these adolescents that were smoking were more likely to have chronic back pain, and then this group was more likely to be hospitalized because of the chronic back pain, where they could have an initial exposure to opioids for treatment there, and then the potential to develop opioid use disorder later in life. And it makes sense because I said previously that people who smoke tend to use opioids chronically. They're less likely to decrease their dose, so they're going to be using it long term. They usually have higher doses. They may require higher doses because they are breaking down the opioids faster, and things like longer use with the initial opioid exposure and higher doses are a contributing factor to the risk of opioid use disorder and for opioid overdose. So just a question for you all, and you can throw some answers out if you want, or we can talk about it next week in the Q&A. Should smoking status be considered when we're prescribing opioids to patients? Well, we can think about it, and then next week in the Q&A session, we'll bring it up again. And if anybody wants to voice their opinions, we can talk about it then. So let's talk about what nicotine does in our body. So it binds to receptors in the brain and then other parts of the body, the central nervous system, where we get that pleasurable effect. It can cause arousal and enhanced vigilance, improvement in task performance. So people are able to concentrate better, they're able to focus, and then there's some anxiety relief. And though this is associated with nicotine binding to the nicotine receptor in your brain or in your central nervous system, something that I was taught with nicotine or smoking and anxiety relief is some of it may also be due to the situation. So for people who smoke, if you're at work and it's stressful, things are going bad, the phone's ringing off the hook, the printer's broken, something's going on, and you decide to go smoke, you're going to get away from the situation. You're going to maybe go outside where it's quiet and nice and take a few deep breaths. So that might have something to do with the anxiety relief too. So when nicotine binds to the receptors in the cardiovascular system, you're going to get increased heart rate, increased cardiac output, your blood pressure is going to go up, and your blood vessels are going to constrict or get smaller. So it's harder for the blood to flow through, and that's why your blood pressure increases. Some other effects, it is an appetite suppressant and can increase your metabolic rate. And we know that weight gain is often a barrier or a fear for people when they talk about smoking cessation. And it can be a skeletal muscle relaxant. So this might be another reason that people with chronic pain are more likely to smoke. So specifically in the brain, nicotine comes in and binds to receptors, and we get a release of dopamine. So what else causes dopamine release? Does anybody want to shout that out?
Opioids,
Exactly.
exercising, chocolate, stuff like that, maybe.
Yeah. So things that are, these things give you pleasure. So opioids, cocaine, amphetamines, eating when you're hungry, drinking when you're thirsty. These are all things that cause opioid release, and they cause euphoria, the pleasurable sensations, and they're reinforcing. So this makes you want to do whatever caused that release again. But we know that there are risks associated with smoking and tobacco and nicotine. So when I talk about the risk, some of it is due to the effect of nicotine, which is a drug, which causes the effects we just talked about. But some of it is because we're inhaling something that's burning. So we're putting burning things that have been burned into our lungs. So it's both of those things. So more than 16 million Americans live with a smoking related disease, and there are more than 480,000 deaths each year. And these deaths are related to cardiovascular and metabolic diseases. So diabetes would be an example of a metabolic disease. Lung cancer, pulmonary diseases, we still see some from secondhand smoke, and then other forms of cancer. So when talking about lung cancer, smoking causes about 90% of deaths. And then there are other forms of cancer that are related to smoking. So you can see on this picture, all of the different colored organs or systems. Those are places where smoking can increase the risk of cancer. For COPD, smoking causes about 80% of those deaths, and then it also increases the risk of coronary heart disease and stroke. But the good news is with cardiovascular disease, when people stop smoking, those risks can decrease. So you can see here that there's a pretty big drop in the first 5 years, and then the smoker's risk of CVD can reach that of someone who has never smoked, possibly in about 10 to 15 years. So that's good to share with people if they're thinking about smoking cessation or, kind of in the earlier stages of thinking about smoking, to let them know that some of the damage can be reversed. So those were kind of general risks to the overall population with the health consequences of nicotine and tobacco use. But there are some risks that are specific to individuals with opioid use disorder. So there seems to be a poorer quality of life with the two substance use disorders, nicotine or tobacco and opioids. The adverse neonatal outcomes seem to be worse compared to individuals with OUD that don't smoke. So birth weights might be lower, and then more severe neonatal abstinence syndrome. So these babies may require higher doses of morphine, and there's premature mortality. So the death rate from tobacco related causes in OUD is twice that of the general population. So we know that there's premature mortality related to smoking, but that's even greater in smokers that have OUD. So let's stop for a second and think about the definition of recovery. So it's a process of change through which individuals improve their health and wellness, live a self directed life, and strive to reach their full potential. So, health and wellness is a part of this. And if we're working with individuals that are in recovery or have a goal of recovery, then I think it's important, because we're focusing on health and wellness, to at least talk about their tobacco use and smoking and try to help them find ways to quit if that's something that is appropriate for them at the time. So I'm going to move on to smoking cessation. And again, this isn't a training program so that you'll be able to go out and lead a smoking cessation group, but I'm just going to talk about some of the things that are available. So we've talked about some behavioral modifications as they relate to other things in this series. So with smoking, one of the brief interventions that's used is the 5 A's. So first you would ask the patient about tobacco use, what form, how often, and then advise the patient to quit. So you want to try to make this as personal to the individual as possible. So if someone has COPD, you might say, I believe that smoking cessation or stopping your nicotine use would be, or tobacco use would be beneficial because you're having these problems with COPD, and it could really help with that. So when we're asking about smoking, we also want to include time to first cigarette. So not just how many cigarettes are you smoking each day, but when you get up in the morning, when do you have your first cigarette? Because this can be an indicator of nicotine dependence. And it makes sense that the shorter amount of time to your first cigarette, you probably are going to be more dependent on nicotine versus somebody who gets up and it's over an hour before they think about their first cigarette of the day. And this also can be an indicator of success with maintaining abstinence from nicotine. So just something else to think about when you're talking to people about their smoking or asking them if they use tobacco. The next parts would be to assess and assist. So we want to see kind of in what stage they are of readiness to be able to quit, or if they have already made an attempt or consider themselves a former tobacco user. And depending on what stage the person is in, that's what kind of assistance that we would offer. So if someone isn't ready to quit or they're not thinking about quitting, we would want to try to do things to help motivate them to think about that. So talk about their risks, rewards that could be associated with smoking cessation, talk to them about roadblocks that they may face and ways that they can manage those, and then repeating this information at different encounters. And then if they're ready to quit, actually helping them form a plan, not just giving them the advice that you should quit, but taking the next step and helping them find ways to do that. And then with people that have quit or former smokers, you want to think about relapse prevention, because just like with anything else we've talked about, people have slips and can return to use. And that doesn't mean that they can't try again. And it's important to remind people that if they stopped smoking and they went for a period of time without cigarettes, and then they had one or two or a week or whatever, that they can quit again. So, and the last A is arrange for follow-up. So we've talked about motivational interviewing a couple of different times in KY Open, so I'm not going to go into details about that, only that some studies have shown that in patients with opioid use disorder, the effect has only been modest. Doesn't mean that it shouldn't be used, but it may only have a modest effect. It can be used with other treatments as well. Something that seemed to be a little more successful with this population compared to some of the other behavioral interventions was contingency management. So offering financial incentives to abstain from tobacco, but this only seemed to work while the financial incentive was being offered. So once that had ended, then the rates of smoking increased in some situations. So you all know that I'm a pharmacist, so we're going to have to talk about medication in this discussion. So here are the FDA approved medications for smoking cessation. And a lot of them are nicotine replacement therapies. And you can see that there are a few different forms, and some of them are over the counter, some of them are prescription only. And there are a couple of prescription options that are not nicotine replacement. And I'm not going to go into a lot of detail on each one. I'm just going to kind of hit the high points and talk about side effects. And then if there's anything unique about the way the drug is administered. So with nicotine replacement therapy, you're providing a non-tobacco source of nicotine. So this is going to help manage withdrawal symptoms while the person is working on changing their behaviors, and then they can decrease their dose of nicotine gradually over time, so the withdrawal isn't as bad. You want to use caution if somebody has cardiovascular diseases. So if they've recently had a heart attack or if they have an arrhythmia, just need to be careful. It doesn't mean they can't use nicotine replacement. It just would probably be better if it was managed by a healthcare professional and it wasn't just the over-the-counter options that people can use on their own. The side effects with the gum and lozenges, a lot of these side effects are related to the way that it's used. So the gum and the lozenge, you're going to get some mouth irritation, some stomach upsets. It's usually okay unless you're not using these products correctly. So if you're just chewing the gum or you're chewing up the lozenge, you're going to get more nicotine all at once. So you're going to have lightheadedness, maybe some nausea, and then again, some irritation. With the patches, you want to think about skin irritation. So if someone has psoriasis or eczema, this might not be the best option. And it can also cause sleep disturbances, which makes sense because people don't smoke when they're asleep. And if you have the patch on and it lasts 24 hours, there's going to be nicotine going into your system while you're asleep, and it is stimulating, so it may disturb your sleep. The nicotine inhaler, some people like this because it mimics some of the behaviors of smoking. You know, it's inhaled through the mouth like a cigarette is, even though it's not inhaled into the lungs. It still kind of mimics the same behavior, but you can get some irritation there. And then with the nasal spray, also some sneezing, watery eyes, runny nose, and irritation, but these symptoms usually lessen over time. So the first non-nicotine product I'm going to talk about is Zyban or bupropion, and it's the sustained release formulation. So this one is dosed twice a day. There are other forms of this drug. You all may recognize the name Wellbutrin or Wellbutrin XL. So this was just the particular dosage form that was studied for smoking cessation. And it's a weak inhibitor of uptake of norepinephrine and dopamine. And the official mechanism is unknown, but they think that this is how it works with smoking cessation because, like we talked about earlier, you get a release of dopamine in the brain when you're smoking. There are some risks. So, people with a seizure disorder shouldn't use this medication, and there are a few groups that can have increased risk of seizures with this drug. Some other warnings, there were reports of neuropsychiatric symptoms, so depression or suicide attempts after this drug was on the market. Some additional studies have been done by the FDA, and the warning is still there, but the studies didn't seem to think that there was as strong of an association with this drug as previously thought. So the adverse effects, insomnia, nausea, vomiting, dizziness, these are very similar to nicotine withdrawal. And the last medication that I'm going to talk about is varenicline or Chantix, and this is the newest one. It was approved in 2006, and also it's a non-nicotine cessation aid. And it is a partial nicotinic receptor agonist. So what else have we talked about that is a partial receptor agonist? So buprenorphine is a partial agonist. So this drug works because it has a high affinity for the nicotine receptor. So it's going to bind to the nicotine receptor before nicotine can. And so if someone is taking this medication and they're smoking, they're not going to get those pleasurable effects from the nicotine. They're not going to get that release of dopamine in their brain. But because it's a partial agonist, you get a little bit of effect from Chantix binding to your nicotine receptors. So it's going to help manage your withdrawal symptoms as well. There are some warnings here. That same neuropsychiatric and suicide risk was on this medication, and the black box warning has been removed from this one as well. One that's kind of unusual for medication, sleepwalking, is a warning that is on this drug. Some of the adverse effects are nausea, insomnia, abnormal dreams, headache. It does stimulate to some extent the nicotine receptors, so you're going to see some effect on sleep. And then less commonly, gastrointestinal side effects. So I included a picture of the dosing card just to show you that it starts out at a lower dose, and you start taking 0.5 milligram daily and then go up to twice a day, and then 1 milligram twice a day. So that helps a little bit with some of the adverse effects, and there are recommendations on decreasing the cigarette smoking as the dose goes up. So they really have a plan for the medication and the number of cigarettes that you're smoking each day. So here is a chart that shows all of the different products, and this is not a head-to-head trial. This was information from about 200 clinical studies, but just to show you all that there are a lot of different options available for smoking cessation as far as medication goes, and they're all going to be better than placebo. So they're all effective. There are different dosage forms. There are options for people based on how they want to use the drug and how often they want to use it, but they're all effective. So specifically for individuals with opioid use disorder, there are some good things. The interest and motivation to quit seems to be about the same as the general population. And most smokers with OUD have made quit attempts, which can be a sign for future success. And patients are willing, but the bad news is they're not receiving offers for help with this issue. And there are gaps in the evidence. So I talked about some of the trials that were done on the medications for smoking cessation, and this group would have been excluded from those trials. So we don't have as much information about how they work specifically in patients that have opioid use disorder or a substance use disorder. And then there are some unique challenges with treatment in patients with OUD. So here is a study that I want to talk about just a little bit because it demonstrates some of the points that I wanted to make. So it was Boston Medical Center from 2016 to 2017, and they looked at about 17,000 patients that were admitted. So they had their smoking status and then information about substance use, and then they looked at the differences in smoking for those different substance use disorders. So you can see here for no substance use disorder, the percent of current smokers was 17.8%. So this is pretty close to the general population rate that we talked about earlier. But then for any substance use disorder, you can see it's much higher. And then specifically for opiates, it's even higher than some of the other substances that they examined. So there was a significant difference between the number of smokers with opioid use disorder versus alcohol and cocaine. And here again, they compared the two populations. All of the people that were admitted that were smokers were offered counseling, nicotine replacement therapy, outpatient referrals, and outpatient nicotine replacement therapy. And you can see here that the numbers were very similar. So the same amount of people accepted counseling, very similar amounts of people accepted nicotine replacement therapy. And then they also ask about motivation to quit, and the numbers, the number of people that were highly motivated in each group were pretty much the same. And just one note, they didn't specifically talk about treatment for opioid use disorder or substance use disorder in this study. There was a component that talked about the addiction consult service, but we didn't get information about whether the patients were offered buprenorphine or anything like that. So let's look at quit ratios. So this means the proportion of former smokers among the full sample of lifetime smokers. And this information was taken from the National Survey on Drug Use and Health from 2002 to 2018. So if you look at the group that had opioid misuse and OUD, the quit ratio here was 18 and for OUD was 10. But when you look at the population without opioid misuse or without opioid use disorder, it was 48%. So there's a big difference in the number of people who are quitting cigarette smoking in these populations. And then other estimates show that success rates are about 1/4 of that of non-substance users. So why aren't people quitting at the same rate, or why are there more smokers with opioid use disorder? So let's talk about some of the barriers to this that might be specific to patients with OUD. So that same study of people in the hospital, there was a part of that where they interviewed 20 individuals that were seen by the addiction consult service, and they talked to them about some of the barriers that they faced. So one was exposure to tobacco, and a quote that was used that can demonstrate this, or a quote that was given: at a methadone clinic, everyone in line is smoking, so it's a trigger. They said that there is a lack of health professional support, so people aren't being offered these services. When high, there's a little concern about health. So one individual said, when I use drugs, I'm not thinking about my health. People are worried about the effect on sobriety if they're beginning treatment, or about being overwhelmed with treating their tobacco use and their substance use. Someone said smoking takes my mind off cravings to do crack or heroin. There was a belief, or there was opinions expressed that heroin use increased cigarette cravings, and some people thought if I could stop using heroin, that I wouldn't want to use cigarettes. And then some people believed that they needed to stop one substance before they could do the other. And then another quote that I thought was really important to share: you don't light up a cigarette and drop dead. So I think that this is a belief that not only is held by patients with opioid use disorder, but with the people that work with these patients and healthcare professionals, because there's more of an imminent risk with an opioid overdose compared to the long-term consequences of smoking. So if you have to pick one thing to focus on, it's going to be more important to think about opioid use, but it doesn't mean that you can't also include tobacco use at some point. Some other barriers that have been mentioned in literature, just the burden of having a chronic disease. Opioid use disorder is a chronic disease. So there are appointments involved, medications involved, trips to the pharmacy. This can add to a patient's burden. There are often psychiatric comorbidities, and individuals with psychiatric issues smoke more often than the general population as well. And there are unique challenges with smoking cessation in that group also. There is a high level of psychological distress. So people may be starting treatment, and that can be a stressful time. They may have recently experienced an opioid overdose. There can be cue-induced cravings. So with taking opioids, just that cue can cause cravings for cigarettes. And it was mentioned with the heroin that caused cravings. And then even with opioids that are used in treatment, there can be cravings based on that. So there have been some reports with methadone maintenance therapy that more cigarettes were smoked like a couple hours after their methadone dose. So there was an association there as well. There may not be as much social support for this population, and then pharmacotherapy, or the medications that are available, seem to be less effective. So if you look at the efficacy, or how well these drugs work, it's consistently lower in opioid dependent smokers, and that includes opioids used in MOUD. So I've highlighted just a few studies here, and I'm not going to talk about them in depth, but I just wanted you all to see that if we look at a few studies where individuals are taking methadone or buprenorphine, and then they're on nicotine replacement or varenicline or one of the other drugs for smoking cessation, the rates of abstinence from nicotine or tobacco are low. The numbers aren't very high. And just to put that in perspective, these are the percentages from that bar graph that I showed that had all of the medications listed that were approved for treatment. So if you compare them to the outcomes that we see here, and again, this isn't a head-to-head study, so we can't really draw conclusions, but if you just think about varenicline or Chantix, it was 29% in the general population. And then here, this study showed only 4%, and this study showed only 13%. So there seems to be a difference in treatment. Okay, so why? There can be adherence issues with medication. This is a problem just across the board, most people have problems with medication adherence, but it has been identified in patients with opioid use disorder. And another proposed reason is a difference in withdrawal from nicotine. So I'm going to look at that just a little bit. There have been reports or some theories that withdrawal is more severe in this population, or that the pattern is atypical for people who are opioid dependent. So this graph shows Minnesota nicotine withdrawal scale scores for people without a substance use disorder who were smokers, and then a group that was opioid dependent. So they were either on methadone or buprenorphine. So at the beginning, at intake, this is before those individuals had stopped smoking, the withdrawal score for the opioid dependent smokers was higher than that of the non-SUD smokers. So with non-SUD, you see a spike in the withdrawal score. So withdrawal goes up pretty quickly when the individual stops smoking. But with the opioid dependent smokers, those withdrawal scores actually went down a little bit. And then after that, there's not a huge difference in the withdrawal score. It was a little bit higher with opioid dependent smokers, but it seemed to change at the same rate. So if the medications that we're using for smoking cessation or nicotine dependence are targeting that withdrawal peak, they help withdrawal symptoms, but this population doesn't have that sudden increase in withdrawal, that might be a reason that they don't work as well. And the study also noted that depression was a better indicator of more severe withdrawal than opioid dependence was. There can be some cultural barriers. So we had the quote earlier about everyone in the line at the methadone clinic smoking. Just the environment overall, smoking is more common and it's more accepted. So things that we can think about to change the environment: denormalization of tobacco use. Some campuses may be smoke-free. So is that something that's going to help with kind of the whole culture around smoking here? And then the training of treatment staff and the attitudes towards smoking, does that make an impact on the success of people who are trying to stop smoking? So even with all of the challenges, co-treatment of nicotine or tobacco use with opioid use is recommended. And at the very least, reports show or studies show that smoking cessation does not destabilize progress. So it's not going to make it harder, it's not going to affect treatment retention, and it may actually help with outcomes. So one meta-analysis, this looked at a bunch of different studies, and their conclusion was that individuals who were treated simultaneously, so for tobacco and other substances at the same time, they were 25% more likely to sustain recovery. And then another example of this, individuals who smoked during detoxification had higher opioid cravings and lower retention in treatment compared to those individuals who were either not allowed to smoke, so in a smoke-free environment, or just who did not smoke. So cravings and retention, cravings were higher, retention was lower. Something else that can be seen as a barrier is the availability of smoking cessation programs and treatment facilities. So a couple of examples here. Methadone maintenance clinics, in a survey, 73% provided brief advice to quit. Only 18% offered individual or group smoking cessation counseling, and then only 12% prescribed nicotine replacement therapy. So it was introduced and people were given advice to quit, but they weren't actually given tools or assistance with developing their treatment plan. And then also there was a range of 29 to 42% of treatment centers that offered tobacco cessation. And some of the reasons that were proposed of why it wasn't higher, people were afraid that the census would drop, that if their patients thought that they were going to try to make them stop smoking, that the patients wouldn't want to be there. They felt like patients were not interested. And this may not be the case because other information points to the interest in smoking cessation and the motivation to quit to be about the same as the general population. And then they also said that their clinicians lacked skills and there were competing demands. So, like I mentioned earlier, when we're thinking about the risk of opioid overdose versus smoking, those are competing demands, and opioid use is going to be the one that we want to try to target first. So I want to throw in a poll question here. So we can't talk about smoking and cigarettes without bringing up electronic cigarettes and vaping. So do you all think that e-cigarettes help people stop tobacco use? True or false? So yeah, about half and half. Thank you all for answering that question. So e-cigarettes, they are seen as less harmful than traditional cigarettes, and they're perceived as helpful with quitting cigarettes. We don't have enough good data to support that, and they aren't approved by the FDA to use for smoking cessation. But I know that is a tool that is commonly used, and a lot of people hold that belief. But one thing that we have to think about with the e-cigarettes is that most people don't completely discontinue traditional cigarettes. So they're still getting the risk from smoking. Findings are mixed as to whether this is helpful with smoking cessation in smokers with substance use disorders, but we do know that the prevalence of use and of using e-cigarettes and traditional cigarettes is high among individuals with substance use disorder. And there is a connection between e-cigarette use and opioid use. So in one survey, it was found that moderate to daily e-cigarette users had a higher prevalence. They called it extra medical opioid use. I assume that means opioid misuse. But they were more likely to use opioids in a non-medical way compared to infrequent users. And we know that this trend is increasing. It's still not as high as traditional cigarette use. Right now, the latest estimate is 4.5% of adults use e-cigarettes, but we know that it has increased in the younger population. So if you look on the right here, this is prevalence among never smokers, and this is the 18 to 24-year-old group. The trend is increasing. So this means that people that have never smoked are being exposed to nicotine and potentially becoming dependent on nicotine. And studies have shown that people who use daily electronic cigarettes, they usually progress on to traditional cigarette use. There are some health risks. So some of the flavoring chemicals are not really meant to be inhaled. They might be okay for ingestion, but they're not really meant to be put into your lungs. You're still getting carcinogens and toxic chemicals. And there was a condition called popcorn lung that was associated with people that worked in factories that made microwave popcorn. So one of the flavorings that was used in this environment led to the workers having scarring of their air sacs that led to thickening and narrowing of their airways, and it made it harder to breathe. But it is now being seen in e-cigarette users. And then, we're heating up things and that changes chemicals and that's still going into your lungs and can cause problems. Here's a little information about opinions related to e-cigarette use. So this was from adult cigarette smokers who were admitted for detoxification for alcohol or opioid use disorders. So they compared the opinions of dual smokers to people that exclusively smoked cigarettes. And they found that those who did both believed that the e-cigarettes helped people quit and that they preferred that form of treatment to other things like nicotine patches or gum. And they believed that they were easier to obtain than the nicotine patches or gum. So I know that every pharmacy I've ever been in or worked in has had this available. So I'm not sure where the ease of access difference would be there, but does this tell us that people who are using e-cigarettes, is this a sign that they're ready to quit? Does that help us know that we should be talking to them about their tobacco use and they might be willing to accept help with that? So I'm not going to go into a lot of depth about resources, but just mention a couple of things that can be helpful. So there is the option of pharmacists being able to help with tobacco cessation. There is a board approved protocol. So pharmacists can work with the prescriber and be able to offer treatment for smoking cessation, pharmacologic treatment. And it's similar to the protocol that is available that allows pharmacists to administer Vivitrol. So, like I said, it's approved by a physician and there are criteria that have to be met and there's training and education that the pharmacist has to do. But with this, pharmacists would be able to dispense any approved medication for smoking cessation. So that includes all of the nicotine replacement therapies and bupropion and varenicline or Chantix. So that would take out going to a prescriber and getting a prescription and bringing it to the pharmacy for those things. It could be kind of a one-stop process. I don't know how much this is used in practice, but it is something that's available. And then if you Google smoking cessation, a lot of information comes up. So there are a lot of different online resources. There is something from SAMHSA that is specific for substance use disorder treatment settings. The CDC has a lot of information. RX for Change is something I think is useful, especially if you're in a facility that wants to offer smoking cessation, but you need to train your staff, because we saw some of the earlier barriers had to do with staff training or staff knowledge. So they have slide sets available with the information that's already put together. There's continuing education there that I thought could be useful. And then there are telephone quit lines available in each state. And here's the website for Kentucky's. There's a phone number, but we know that many patients with opioid use disorder have unstable phone access or access to a computer. So I'm not sure if this would be a great option, but it is something that is available. Okay. So any comments, questions, feedback?